some cases in the past, and let me tell you, all the cases are alive and healthy till now. So that has been the outcome. And my other colleagues, Dr. Ravinder, Dr. Haresh, will also share their experience later on. So with this, let me welcome Dr. Katrina.
Thank you very much for this very kind introduction. And just let me share my screen. Sorry, I don't know where the problem is here. Let me just, first the screen is here, just give me a second. So. Let me just, I'm sorry, I just have a technical issue here. Just give me a second, please. Warum geht das nicht? Okay, now we are here. Okay, can you see the screen now?
Yes, it's visible, Dr. Katrina.
Yes,
okay,
yes.
I'm sorry for the technical problem, but thank you very much for the very kind introduction. I think it's exciting to discuss this topic today, and I'm overwhelmed by the response, by the friendly introduction, and so I'm very happy to start this exciting session as a speaker. My topic is not only to go through the trick valve, but of course also to elucidate a little bit the etiology and the underlying disease. So if we look at tricuspid valve anatomy, we are aware that this is a multiplanar happening. It's a 3D structure. It's much more difficult to address than any other valve in the heart. And if we talk about tricuspid regurgitation, we have to keep in mind that it's mainly a dilatation of the annulus towards the free wall. And we know that the annulus in severe tricuspid regurgitation tends to become huge. And we also have to keep in mind that there are a lot of important structures in the close proximity, which we have to take into consideration when choosing a device for minimal invasive treatment. I also want to touch shortly on the classification of TR. As most of you will be aware, the classification has been changed recently, mainly under the guidance of Rebecca Hahn and Jose Zamorano, who is also our ECHO core lab for the Tricus clinical trials. And instead of staying with the old graduation of mild, moderate, and severe, there were two more graduations added, massive and torrential, in order to better elucidate the degree and more in a multi-parametric and semi-quantitative approach instead of purely qualitative. So the torrential nature of TR to be taken into account has happened with this graduation. If we look at etiology, we will be mainly targeting patients with functional or secondary TR, which also is like, pardon me? Which is about more than 80% of the technology. So if we look at the right ventricular annulus, can you hear me? Yeah, okay, because I have an echo. I have quite a strong echo. So if we look at the etiology, then the main patients we will be targeting is, of course, patients with functional or secondary TR, which represent more than 80% of the patient population. So these typically are patients with left side valve disease, atrial fibrillation, chronic right ventricular stimulation, pacemaker leads, but more and more we are also targeting systemic diseases such as Chagas disease, carcinoid, and many other more to be determined. Just to touch shortly on structural or primary, these are not main targets for minimal invasive technologies. This is mainly Epstein as well as rheumatic disease, endocarditis, or post-drug abuse. if we look at the prevalence of TR, and I have to say in the beginning of our development, I was not very fond of this because I thought, what do you do with tricuspid regurgitation? But if you look at the numbers, and these are numbers from the US, then we have to acknowledge that we have about 1.6 million cases with an annual new appearance of TR of about 250,000 cases. But what catches the eye is that if you look at the comparison between annual mitral surgeries, and this has been some years ago, but nevertheless, the relationship is still the same. We have almost only 1/10 of tricuspid surgeries, and I want to elucidate further on this later in this talk. If we look at the prevalence compared to aortic stenosis and mitral regurgitation, yes, mitral is the biggest field, but tricuspid regurgitation is almost as big as aortic stenosis. So we have a huge field and a lot of patients that need our attention. Why is it important? Why do we want to treat TR? If we look at those studies, then we have to acknowledge that tricuspid valve disease is a severe condition with an impact on long-term survival, especially in patients with chronic heart failure and left ventricular dysfunction. And this has been shown nicely in the study from the Californian group, showing that even in the presence of moderate, but more so severe TR, survival is severely impacted. The study from Vienna in the middle shows that the combined endpoint of death, heart transplantation, left ventricular assist device is much more likely to be reached in patients with moderate and severe TR. So 5-year event freedom is severely impacted in the presence of moderate and severe TR. And the same is true for patients with impaired left ventricular function. So in the presence of severe TR, we have an impact of survival. Those patients need our attention and treatment. This, I think, is very important because it shows that patients with left-sided valve disease have an almost 30% mortality per year. A combination of atrial fibrillation, death, and heart failure has hospitalization. And I have to say, from the patient we are screening for TricValve, we can see that many of them had almost more than 50% had left-sided valve surgery. So this is also a patient group that has to be monitored. Also patients with left ventricular function, they really need our attention. What happens if we treat mitral regurgitation? And I think this is a very recent topic. We have a lot of possibilities now to treat mitral disease. In the presence of moderate to severe tricuspid regurgitation, we will still have a significant impact on mortality. So it will not help us to only address the mitral valve. We need to take the tricuspid valve into consideration. And this has been shown in several large clinical trials. Same is true if we combine transcatheter mitral and aortic interventions. And I think this is like our most recent situation. We have treated a patient with mitral clip, we've done TAVI. Does tricuspid regurgitation impact survival? Yes, it does. It does impact survival in the presence after TAVI or after combined disease. In the presence of moderate to severe TR, the patient will have a worse prognosis. So we have to take this into consideration when treating those patients. Why do we not send them to surgery? I have to say I had a lot of surgeons in my career who were very happy about our development of a minimal invasive device to treat patients for tricuspid regurgitation, as mortality of those patients is unacceptably high. We are not only talking about a valve disease, we are talking about the right ventricular disease. So isolated TR might be good to operate on. As soon as the comorbidities are added, mortality goes up to over 30%. What is the transcatheter tricuspid landscape at the moment? And we are aware that most of the technologies available today are mimicking surgical approaches, such as the direct suture annuloplasty, of course, the direct ring annuloplasty, such as the Cardioband, and the most widely used devices mimicking Clover and Hetzer stitches, which is the TriClip and the Pascal. If we go into valve replacement, then the only device currently clinically available is the TricValve for heterotopic valve replacement. So many devices are already available in the early stage of disease, but as soon as we come to a more progressed right ventricular failure, the TricValve remains the most preferable option. And this is shown very nicely in this algorithm, how to select your device for tricuspid disease. And here we see that in phase 1 and phase 2, with a mild tricuspid annulus dilatation and moderate tethering, we can use the annuloplasty devices, we can still use the cooptation devices, but as soon as we enter phase 3, with severe tricuspid annulus dilatation and tethering and a large cooptation, we will not be able to use those devices. So we will have here the TricValve is the device of choice, especially if pacemaker leads are present. And these are numbers from Spain, and I think it's just interesting to show them because the majority of the patients were, of course, treated with annuloplasty device, with cooptation devices such as TriClip, MitraClip. But after this, the CAVI, so that means the TricValve system, has been the most widely used device. And more than 50 TricValve cases have been made in the last year in Spain, which I think is also remarkable. I just want to go shortly through the baseline characteristics because I think they represent the patients we are targeting. So they are not that old. They are in average in their 70s. They are, half of them are female. They have a high Euro score. The majority is functional. They have pacemaker leads, they have atrial fibrillation, they have renal failure, they have heart failure, ascites, peripheral edema, and they are in high NYHA classes 3 and 4. So we are treating a very ill patient cohort. And this is important if we want to choose our patients and to determine who should be treated and at which point. We have to take into consideration demographics, clinical symptoms, comorbidities, cardiac disease, surgical characteristics, but of course we also have to take into consideration the clinical, the anatomy, just as the TR severity, annulus size, tricuspid valve morphology, right ventricular remodeling, and pulmonary vascular resistance. And all of these factors have to be included to lead to a heart team decision. And what we see at the moment is that in many of our patients, we treat them too late. We might have already passed the point of no return. And if we look at this graphic, then we can see that the progression to symptomatic, the point of no return, or the point where response is likely and recovery is still possible, is much earlier than we tend to treat patients now. Now we wait for the patient to become severely symptomatic until he does not respond to
everybody just mute their mics?
Until he cannot respond on diuretics anymore. So this is important for the heart team decision making to keep this in mind. Why is it important to have a safe and reliable device? Because we know that procedural success is associated with reduced mortality. So it is important to be sure that your procedure can be successful. So to summarize the first part of my talk, I would like to state that we know that functional TR is common and it's associated with a poor prognosis. The majority of the patients are currently not offered any intervention. We keep them on diuretics until there is no way out. Transcatheter options may be impactful in many patients that are denied surgery, and patient selection and timing of intervention is essential for valvular interventions. Current devices may be more effective in less advanced patients, but I think this is a general thing. And of course, we have to increase patients' and physicians' awareness that this is essential for earlier referral for Tricus valve intervention. And with earlier referral and treatment of patients with significant TR is to avoid patients reaching end-stage right heart failure and to allow the treatment of patients who are most likely to benefit. So this leads over to the topic of today. The TricValve transcatheter bicaval valve system, which consists of 2 dedicated valves. And I would like just to show you a short introduction of how the system is deployed. Here you can see a normally functioning heart. You can see the tricuspid valve, inferior and superior vena cava in their normal anatomical setting. If we then see the heart with tricuspid insufficiency, we see annulus dilatation, we see a dilatation of the right ventricle, and this is where we do not address the tricuspid valve directly, but we will have 2 valves, dedicated valves, implanted in the superior and inferior vena cava in order to prevent backflow and improve symptoms. So if we look at the 2 dedicated valves, and I have to stress that these are the only 2 dedicated valves for caval implantation available, you will see on the left side the short skirt of the inferior vena cava valve in order to prevent hepatic vein occlusion and paravalvular leakage. It's a bovine pericardium and it's a high-strength self-expandable nitinol stent frame. For the superior vena cava valve, you can see the crown, as I call it, the upper part, which is meant to be in the confluence in the brachiocephalicus. Then you have the belly, which will anchor in the superior vena cava, and the valve-bearing segment facing the right atrium. All of the valves come pre-mounted. I think this is very important nowadays. It's with the proprietary P&F tri-tissue technology. So we apply dehydration and anti-calcification treatment. And this, of course, helps to reduce preparation time significantly. The handling of the valves is reduced. In size, as you do not need anyone in the cath lab, and the risk of contamination. And it's much easier to use as it's an off-the-shelf technology. In the preclinical testing, we could show that the calcium content is reduced, that the integrity of the collagen structure is preserved, and that we have a decrease in thickness and an increase in tensile resistance. And all of this has been shown during testing approval. TricValve comes in several sizes, thus enabling us to treat a huge variety of anatomies and patients. As I said, it consists of 2 self-expanding biological valves, and it's especially intended for patients at extreme risk or who are deemed inoperable for open surgical therapy. This is how it should look once your valves are properly implanted. We like to do 3D reconstructions with virtual implantation before challenging cases. And the 2 valves should avoid backflow, they reduce congestion, and they promote right ventricular remodeling. So in order to reduce symptoms and mortality. This is again the valve design for the superior vena cava valve. As I said, it's a self-expandable valve technology with crown and belly anchoring in the superior vena cava, and this is again the inferior vena cava valve. This is a nice example from the University of Salamanca, and this is how it shows how important it is to have a proper CT planning and the possibility of using CT X-ray fusion to guide implantation in order to reduce fluoroscopy time, but of course also contrast in those patients with renal failure. I think we see more about the implantation process later. So what are the important parameters that we need to consider when planning a TricValve procedure? First of all, we have to determine the anatomic suitability, which is done by a dedicated CT scan. But then we also have to know about the V-wave and the right ventricular function. And in the clinical trial, we were excluding patients with severe pulmonary hypertension in order not to mix up 2 different entities. As I already stressed, these are the parameters for the clinical trial, so this will be reevaluated and probably will be softened for the daily use. These are the measurement points, which at the moment, which are also in instructions for use for superior and inferior vena cava. And this is again the 3D simulation of how it looks once the valves are implanted. So in conclusion, I think it's important that the TricValve procedure is a very easy procedure. It has a fast learning curve, and anyone who is familiar with self-expandable valves in the TAVI position will be very easily able to place the TricValve. It has a very high procedural success rate, and I want to say that it's almost 100% if you do your CT planning appropriate, because it's mainly migration that can cause a problem. It's a very fast procedure. This is also very important because I think first we are treating very ill patients. First and second, we want to know if we enter the cath lab, when do we get out of the cath lab? How can we plan our day and how many procedures can we include? As I said, it's pre-mounted, so the manipulation time is short. It's an off-the-shelf technology, very similar to stents. It's a venous system access with a 27 French, and we have a 90% recapture range for replacement and repositioning of the valve, although I have to say it's almost never necessary, but it is possible. What is important is you do not disturb any right heart structures, so there's no interference with the annulus, and even if you wish to place a pacemaker lead or another transcatheter method through the valve, this is clearly possible. It's not mandatory to have TEE. It's sufficient to have TTE. You do not need sedation and has a good visibility. And of course, the risk of contamination is also decreased. So I'm very happy to hand over to the next speaker to show us more about the TricValve, and Dhanyavad.
Thank you, Dr. Katrina. But before the Dr. Guglielmi starts his presentation, let everybody just mute their, just do a mute on your screens because it is disturbing everybody. So please mute everybody's screen. Can somebody do it? Okay, that's better. Now, thank you very much. And let Dr. Agreli, who is the Chief Research and Development, take us through the process and through this details of this valve. Thank you.
Thank you. Let me share my screen here. I will overlap a little the information with Katarina because I will talk about the technical specification of the devices. And it's, are you seeing my screen? Okay, then it's, as she presented, we have TricValve as a system of two self-expandable valves, biological valves, for treatment of tricuspid insufficiency. And it's important to us to consider that we are talking about a heterotopic implantation. Then we are treating the disease here with specific devices for heterotopical implantation. Then during our development, we designed devices specifically for the Caval application. We are not using aortic valves or other valves to Caval application. Then we face a lot of challenges that we need to move forward with this in this application, because for such kind of patient, we have very enlarged vessels, large cava, superior and inferior cavas, with anatomy with a severe variation, because we see this right atrium deformation and enlargement changing the anatomy of the cavas. We see in most of the cases tapered cavas or bending that it's not common in the venous system. And for these devices, we are implanting valves in a system with a very low pressure and a very slow velocity blood flow in this system. Then our stents and our leaflets, they are especially designed for this application. Then we need to have a valve working with low pressure gradients. Then the leaflets, they are softer than other valves, and they need to close and open completely to have the final result according our specification. Then these parts, they have a special designed features. Then for superior cava, we have a special design of the valve to accommodate in this part, and we see in after computer tomography, after evaluation, that most of the cases we have this angulation in the cava, and we have a tapered superior cava. Then we need to develop a device with different parts to have this appropriate fixation and sealing. And as Katarina previously showed, we have this stent with a belly and a crown. The crown, it's a part of the stent with low radial force, and we use this for the stabilization of the system during deployment and after deployment to guarantee a correct alignment with the superior cava. In some cases, when we have a short superior cava, we need to protrude this crown in the innominated vein or in brachiocephalic vein. We need to move a little higher the valve to have this accommodation and to keep the belly, this spherical stent, at the level of the pulmonary artery, because this specially shaped stent will force against the wall and keep a pushing force up down to keep the valve always higher, to avoid the embolization of the valve. And this is important. We have this covered part of the stent. It's a pericardium covered valve for sealing and for anchoring. At the same part of the valve, then you will be responsible for the sealing and the anchoring of the valve. And in the lower part of the device, we have the valve. We can see that the valve is smaller. The valve, most of the case, will not be touching the walls of the vein. And we have a stent with high radial force to avoid any deformation and any kind of malfunction of the valve after deployment. Then we will have the belly at the level of pulmonary artery. We will see this during the implantation presentation, that we need to keep this above the pulmonary artery to keep this sealing and fixation of the device. The same special design we have for the inferior cava. Most of the images that we see of the inferior cava, we see a very straight cava. But when we use other projection and multiplanar reconstruction or 3D reconstruction for these patients, we see that we have some bending or angulation in the transition part from the atrium to the cava, because we have this enlargement of the atrium and the cavas. Then we need to consider this, and we move this information to the design of the stent. Then we have this, it's a different valve. We have this hourglass shaped stent. We have a small covered section where we have the valve. And in this device, the inferior valve, we have the sealing zone in the upper part of the stent. And we have radial force in this part, but this part it's for sealing. And we will have the anchoring in the bottom part of the stent, where we have low radial force, but with large diameter. Then we increase the area, the contact area with the vein, and we avoid any rupture or damage to the vein wall. Here we see the dimension of the stents. Then in most of the cases, we need to adjust precisely the position of the upper part to avoid a protrusion inside the atrium and possible conflict with the septum wall, and we cannot put too low to avoid the obstruction or occlusion of the hepatic vein. Then we have, again, we have a stent with different properties and characteristics in different levels to have the appropriate fixation and sealing of this device. Again, we have a valve specifically for the venous application with soft leaflets to avoid a high gradient to allow the full movement of this device in a different blood flow with low pressure and very low velocity. As Katarina mentioned it before, all the valves that we have, we use dry tissue. It's a characteristic of our device, and these valves, they are preloaded in the delivery system. It's an important feature in these devices, and this is the device. We have the preloaded valves. We have a 28 French delivery device, and this device, they have a high columnar strength to allow a very precise positioning without bending or kinking of the delivery device. And this is allow us to have a recapturable device until 80–90% of deployment, and we keep tensile during the deployment without any deformation of the delivery device. This is how we will find the delivery device. They are in a blister, and the device is ready for use. Then we just need to flush the device. We can see that the tip is a little opened to easily remove the air inside the delivery system and to flush. We just need to flush with 60 to 80 saline solution, cc's of saline solution to remove the air and to rehydrate the valve. Then it's a 1 or 2 minutes operation. Then we just close the capsule where the valve is located, and it's ready for implantation. Here is how we operate this device. We will just move the red parts of the delivery device. Then it's a device, but with a knob for a very controlled and slow deployment. This is another characteristic of this device. We are implanting a valve in a low pressure system. Then we do not need to go fast for deployment. Then we can deploy the valve very slow to wait for the nitinol, the metal of the frames to conformate the cannulas, and we can test if it's in the right position. Then we deploy at 1/3 of the valve, we check and test, then we follow with the deployment. If not in a good position, then we can recapture the system and reposition it and follow with the implantation. Then we will just move these red parts. It's a very simple device. It's a very easily to handle this device. Then first we will remove the air of the system with saline solution. This operation will rehydrate the valve. Then we will be ready for implantation. Then it's just rotate this knob in the distal part of the device. For clockwise, we will open the device, we will deploy the valve. Anti-clockwise, we will close or recapture the device. After implantation, it's just unlock this knob, and then we will do the fast tip recovery to remove the device. It's a very simple operation of this device, and as this is the same animation to show the implantation of the valve, but here we have this final comments, and it's important to keep this in mind when we think about the TricValve device. We have a specially designed valves and a specially designed delivery system for the bicaval application. We have off-the-shelf devices with specially designed stents for most of the patients with enlargement in the superior and inferior cavas. It's a very easy preparation device, and the device is ready to use. And with few and simple steps, we will have the safe and precise valve deployment. Thank you.
Thank you, Gilham. Sir, now Dr. Rishipuri would be speaking to us. Request you to have flashed his profile on the screen.
Thanks, Dr. Chandra, and thanks everyone. I'm just going to share my screen. Hopefully you guys can see that. Can you guys see my screen?
There you are, Dr. Rishi.
Okay. So thanks for the opportunity to present. As you can guess by my name, my parents are from India, and so it's a pleasure to be able to present some of the European data, in fact, on this very exciting technology. Here are my, let me just see if I can move these slides. Here we are. Here are my disclosures. Just move this to the next one. So as you probably all know, TAVI was a breakthrough technology in structural heart. And when we look at TAVI is relatively simple when we look at some of the technologies and devices that we're trying to apply to the mitral and tricuspid space. And so, as you can certainly appreciate, the path to successfully treating tricuspid valves has been a little more complex and continues to remain complex. And this is really driven by the anatomy and some of the anatomical and physiological constraints that we encounter with patients with significant tricuspid valve disease that harbor a number of anatomical issues such as large coaptation gaps, significant tethering, significant angular dilatation. Often these patients have pulmonary hypertension, right ventricular dysfunction. And so when you're faced with some of those anatomical constraints, some of the earlier transcatheter device and even emerging transcatheter device technologies are not really going to work effectively. And that is where CAVI or caval valve implantation comes into the picture. And so when we look at the device landscape of CAVI, it really goes back and is not something that has been conceptualized in the last 2 or 3 years. This has been a 10 to 12 year course. Some of the earlier devices were really used off-label to treat patients on a compassionate use plan who really had no hope. And we can see here some of the summary of that data. As you can appreciate, these patients are quite sick, but nevertheless, procedural success in some of these very earlier devices was reasonable at 90%. That tells us that with a dedicated device, custom-made device for the cava anatomy, one can achieve very high procedural success. You know, there were about one in 10 of these patients who needed open surgery. Unsurprising, because the earlier device landscape was not really geared towards the anatomy and the physiological issues that Guilherme alluded to. In-hospital mortality was nearly 20%. That speaks to how sick some of these patients were. And the 30-day mortality was 1 in 5, again, speaking to the same issue. When we look at the TricValve developmental pathway, it really has been quite impressive, and this is actually evolving. This started off with a special access program that is burgeoning around the world now, but really the protocol-driven sort of studies are the ones that I'm going to focus on today in terms of summarizing some of the results. The first in man or early feasibility study included 9 patients, and this was the Tricus study. And the CE mark trial is undergoing follow-up, patient follow-up, was conducted in Spain and Austria, and I'll also share some of these data with you. So when we look at the baseline characteristics of the first in man or EFS study, as well as the more recently enrolled Tricus Euro study, you can see that this represents a standard cohort of patients with severe tricuspid regurgitation who are at high risk for surgery. 1 in 5 of these patients, more so in the Tricus Euro cohort had permanent pacemakers. And as you know, having pacemaker leads can pose a challenge if you are looking to implant a tricuspid valve or undertake edge-to-edge tricuspid repair. And so this is really the reality of real-world data. We need devices that allow us to navigate some of these sort of complexities. A lot of these patients had previous open heart surgery. Euro scores early on were obviously higher because these were the extreme risk patients, and we see the Euro risk trending downwards in some of the more recent patients that were enrolled. Patients with low GFR, this is going to be dealing with tricuspid, transcatheter tricuspid valve solutions, because invariably these patients almost always have some degree of renal insufficiency. And so finding out or iterating means of not only assessing these patients, perhaps instead with CT, with MRI, using contrast-sparing techniques. This is where some of the iteration in procedural technique is going to take place as we start to sort of broaden the device landscape with these technologies. When we look at some of the procedural results, really quite impressive for a very early technology. In-hospital mortality, when you use a dedicated device, has so far 0. Technical and procedural success are well and truly into the 90% range. Really only very few or one device embolization that was and you know, this really can occur in the most extreme anatomies or when you are perhaps not sure about your imaging. And this really, most of us who do structural procedures, most of the planning and anticipation of complications and can be anticipated in your pre-procedural imaging. And so CT or MRI is really important. You can really predict 80% of what's going to happen in the case from the pre-procedural imaging. Really minimal to 0 conversion to surgery, and length of hospital stay around about a week, but I'm sure will start to decline as we start to improve our experience. In our institution, we have a number of our patients with TAVI who we send home the same day. When you think about how TAVI started and where we are now, we're going to see the same results. We're even sending MitraClips home the same day. This is a venous procedure. I don't see any reason why a TricValve patient couldn't go home the same day once we start to get good at this procedure and do lots of it. Let's look at some of the functional outcomes that are very important. You can see here some very promising data. You know, these are limited numbers. Not all of the patients, not all of the 38 patients have been followed up yet, but we're seeing very important trends in the right direction, that these patients are deriving improvements in their functional outcomes. And we see a halving of the patients who are at the upper end of the NYH scale, which is quite impressive, and in line with some of the other devices. When you go to agencies that look at device labeling and organizations such as the FDA, what they look for are improvements in some of the objective measures of patient well-being. So 6-minute walk distance, you know, is an important surrogate of patient well-being and morbidity and mortality. In fact, the FDA looks more closely at the Kansas City Cardiomyopathy Questionnaire or the KCCQ-12 score. And what the FDA look for is a delta KCCQ of 10 to 15 points. And what you can see here, developing early, again, this is limited number of patients, we can see some very, very promising improvements in the KCCQ.
Dr. Rishi, request you to unmute yourself, sir.
Can you hear me now?
Yes, you are audible, sir.
Perfect.
Thank you.
As I was saying before, I'm not sure how much of the last slide you captured, but you know, these functional outcome scores are incredibly important in terms of correlating with patient morbidity and mortality. And the FDA looked specifically at the KCCQ score, a delta of 10 to 15, as an important surrogate for patient well-being. And we're certainly seeing some of these results play out in the limited number of patients that have undergone 6 to 12-month follow-up. looking at functional outcomes from a weight perspective, we see trends in reductions in body weight. You know, some of my colleagues who have implanted this device in Europe tell me that those patients in whom had florid right heart failure within 36 to 48 hours, there was significant improvements in the degree of their edema, which is very promising. When we look at some of the imaging parameters that follow up, the tricuspid annular plane systolic excursion index, the right atrial dimensions, the pulmonary pressures, ejection fractions, we're not really seeing any surprises here, which is reassuring. You know, we are seeing some reverse remodeling of the right ventricle, at least on echo, moving all in the right direction, both at the base of the RV and mid-ventricular. This is an interesting CAT scan provided by one of my colleagues in Spain who has some nice experience with the device, and we're hoping to see some more of these sort of MRI or CT pre and post results to give us more of a global understanding of what's happening to the right heart pre and post. And we are seeing some remodeling in a favorable direction with important reductions in volume, at least in this case, and hoping to see that in some other cases as we move forward and build our experience with this device. From a hemodynamic perspective, you know, we do see significant improvements in the V wave in the IVC, obviously the Doppler hepatic backflow and the hepatic veins, and no real significant changes in the mean right atrial pressures. So again, no major surprises here from a hemodynamic perspective. When we look at some laboratory indices, you know, in some patients, we expect to see perhaps an improvement in creatinine. Most of the patients have no change in their creatinine. We do see perhaps a trend towards a slight increase in NT-proBNP, but nothing alarming in that sense at this point in time. When we look at some of the hepatic markers, such as transaminases, you know, we start to see some evidence of decongestion, which you know, we'd expect and is encouraging. From the major adverse cardiovascular events perspective, thus far, there's been no device-related mortality, which is important. There's been a hematoma at the access site. Remembering this is a large bore venous access. We've had some patients with respiratory infections. There have been patients that have been readmitted with heart failure. And there was one unfortunate patient that fell and had a subdural hematoma, but these do not appear to be device-related, and these early data are encouraging. So to wrap up, from my perspective, the TricValve Cavi system represents a novel, promising, less invasive and efficient concept for treating severe tricuspid regurgitation. The early clinical experience appears very promising. We are awaiting follow-up data for CE mark approval, and there are plans to bring this device to the US. I can't wait to get my hands on it. And nicely, you know, the company have been designated breakthrough device technology by the FDA, which is really an important step in the right direction. We really look forward to working with the company in bringing this to the US, where there's a huge unmet need for this device. We're seeing improvements in early functional status, quality of life metrics, and importantly, if you have pacemaker leads, and if ultimately you need to have a dedicated tricuspid valve device in the future, this technology allows all future options to be used. Thanks for your time.
Thank you, Dr. Rishi. I think this was wonderful to see you again after many years.
Yeah.
I think, yeah, we met in Australia.
Indeed, yeah.
Yes. Wonderful presentation, and we also had some positive experiences. In fact, very positive experiences with this device, and we have us here today, Dr. Haresh, and start his presentation.
Can you hear me, guys? Can I be heard?
Yes, Dr. Harish, you are audible.
I'm just going to share my screen.
Yes, sir, we can hear you, sir.
Yeah.
So I'm going to share this case of tricuspid valve intervention. We were probably the first or second case in India we did. At that time, this device was very primitive. So this was a 67-year-old female, a resident of Kuwait, a non-hypertensive, dyslipidemic, non-diabetic, She had a status post single chamber pacemaker implantation for heart block, intermittent AF with old left hemiparesis. She had recurrent ascites, pedal edema, anorexia, bleeding tendencies, fatigue, weakness, and renal dysfunction. And you can see her picture, that's how her abdomen looked. And the USG abdomen showed a shrunken liver with post-echo texture, dilated IVC, marked ascites, normal sized spleen. Bilirubin at that time in Kuwait in June 2018 was of 11.9, hemoglobin of 6.1, INR of 1.9, and AST, ALT was thrice normal. He had portal gastropathy on OGD-scopy, small esophageal varices, angiodysplasia. And this was her ECG, which was the base rhythm. So echo in Kuwait showed a biatrial enlargement, normal sized right ventricle, normal sized LV, observed biventricular systolic function, moderate to severe mitral regurgitation, severe tricuspid regurgitation, mild pulmonary hypertension. Angiogram showed the following features, nothing major. She was referred to a surgeon for mitral valve replacement with tricuspid valve annuloplasty, and this is what the surgeon wrote. He clearly declined that surgery is not possible in her, and he would say we should deal with the tricuspid valve using mitral clip. He came to us to India around sometime in 2018. We evaluated her. Her echo showed moderate mitral regurgitation. It was not that severe, but she had severe tricuspid regurgitation, good biventricular function, mild pulmonary hypertension. So the plan was to reduce the hepatic congestion. If Dr. Praveen Chandra would remember, I asked him about this patient in India valves, and that's when he was the one who suggested, why should you not think about the trick valve, which was just newly come, or he had seen a case of that. So we went ahead and thought we should plan a trick valve. We explained to the relatives that this may help you reduce the hepatic congestion and future make you a candidate for maybe repair of the mitral valve, or we will save her from a hepatic transplant and maybe a heart transplant if she doesn't settle. So we looked into literature and we read the first man application of approach to tricuspid research, which was by Dr. Hans Figula. We read and understood more about the valve. This is how the valve looked, but the delivery system was not as simple. So I'm not going to go into the details of the valve. This has been described already. So I'm not going to go into the details of how the valve is. But this was how bad the loader used to be that time. So we had to take about half an hour to 1 hour to load a valve. I'm told now it's already preloaded. So loading that valve was an effort during those times. And these are dimensions which have been discussed. And these are the CT measurements which we need to order the valve size and the same sizing in the IVC. So we did a diagnostic right heart CAT. Most important, you can't have a severe pulmonary hypertension. It's a contraindication. So you have to rule out significant pulmonary hypertension. We took a bilateral femoral venous access, right 22 French, left 7 French. We took a right radial access for monitoring pressure, a right IJV access to take your pigtail down, heparin as per ACT, and valve was crimped into delivery system, and we used Z sutures for right femoral vein and compression for the IJV. So this was the hemodynamics pre-procedure. This is the RV trace. If you see, and the RA trace, which are equally the same. So RV and RA almost looks the same because of the severe severe tricuspid regurgitation. And you can see a pulmonary artery catheter across. That's very important marker for you to position the SVC valve. So we put this pulmonary artery catheter across, and this was locating how we're going to deploy the pulmonary valve so that it doesn't, you get the right position. And once we were happy with the position, we started deploying the valve. And the valve, as it opened, we reposition it. It can be repositioned at some time till you get the final position going right. This is how it looked. Now, if you inject, you realize that there's flow only in one direction. Then we took another catheter into the hepatic vein to locate the hepatic vein so that the skirt remains above the hepatic vein and does not occlude the hepatic vein. This is how it looks. So you can again see that the valve is flowing in one direction. And this is the last shot. And you realize that there is no backflow into either the SVC or the IVC. This is how it looks. And as was been discussed, with a pacemaker in, it can easily be implanted despite the pacemaker lead being in. It doesn't damage the lead. And this is now you see the pull back from the RA into the vena cava. You can see that the pressure has totally gone down, clearly telling us that this patient has now going to be benefit from reduction of hepatic congestion. So creat in a couple of days went down from 1.7 to 0.6. In OGD scopy and follow-up, she had no varices, she had no ascites, and the LFT returned to normal. And we avoided her hepatic transplant. She's now 2 years down the line. She's back in Kuwait, and she's not had a recurrence of her heart failure, and she's doing well. So this is my case of tricuspid valve, which was done. I'm sure there are better things coming our way. Thank you very much.
Thank you, Dr.
May I just use the opportunity to congratulate on this beautiful case? I can remember it. So fantastic.
Very nice case. Wonderful. So this, we have seen, because now we have the preloaded valve, so it is very easy.
Yeah, that time it was
moves
not.
in so quickly. Yeah, but wonderfully done case, and I must congratulate Dr. Harish for doing this, wonderful case and giving so much relief to this patient.
I think I'm glad I met you in the meeting and asked you about the option.
So it's good to keep meeting. I think we should keep meeting.
Sure.
That's the story. Anyway, so congratulations again, and we can move to the next presentation.
How?
Again the same problem is there. Somebody is.
Ravi, you'll have to unmute, yeah.
Okay, fine. So I think we can have the next presentation. Dr. Ravinder, can we see his presentation?
Sir,
no.
Dr. Chandra.
So if he's not there, so we can have
we
some
don't
discussion.
have Dr. Ravinder Rao.
Yeah.
So he's held up on some emergency. So
okay, no problem.
Open the session for discussion.
So we can have some discussion. Yeah. So let me first give you a small, overall of this valve. And this it's very easy to use this valve. And most of the patients which have been done, there has been no mortality in India also. So it doesn't harm the patient, number one. Number two is it only helps, and the amount of results which we see in our patients has been quite tremendous. This is Dr. C.S. Kundu. Can somebody just mute Dr. Kundu, because it's happening again and again. And the clinical outcomes of this valve has been very positive. So the only limitation or the dimensions of the evidence. So that is where it is. Let me now invite our moderators, Dr. Ajit, if he's there, so to give his insights and comments and his, outlook on this. Dr. Ajit, please. He's not there, I think. Dr. Ajit has. Dr. Patra. Hello.
Yeah. So thank you, Dr. Chandra, for nicely connected session. I think these things should be done a little early where there is a flow reversal, but that IVC and SVC are not dilated enough so that we can't put anything. So with that must be the flow reversal both in the IVC and the IVC diameter. I think it should be near about 30 millimeter. And any more dilatation than that, I think it will be difficult to implant the device right now. So I have no experience, so I should not comment on this anymore. So I leave it to you, and already implanting it in India.
Yeah.
So I think it's
but you agree that, but you agree that there are a lot of patients who are needing this kind of therapy, and since the ease of doing this therapy is so much, it will be a good idea. Right. Okay. So let me ask my other colleagues who are on the panel, and can I request Dr. Ajit if he's there? No.
Dr. Ajit had some emergency, so he had to leave. He's not there. Yeah.
We have Dr. Azam. Dr. Badam Azam. Yes.
Dr. Azam, please come up. Give your.
May I ask a question? Dr. Ravi Kalra from
please, go ahead.
Yeah, I want to know, my only concern is the RA. What happens to the RA? Does it dilate further? Does it go into fibrillation more easily after this? Because the RA is not decompressing now. Anything on that?
So I can just give you the the logic and the the experience which we have. So we have seen that of course logically the RA becomes ventricularized in a sense, and then same way as it was behaving earlier, that will keep enlarging. The RA will keep enlarging, and the chance of having a AF will be extreme. It will be high. It is already high beforehand, so that we cannot kind of mitigate or change. So let me take the comments from my other colleagues. Dr. Rishi, what do you say about this, and Dr. Katrina?
Yeah, so it's an interesting, I mean, clearly we are ventriculizing the atrium. And so when you see some of the early BNP rises, it may reflect a little bit of atrial stretch. Two things to consider: almost all these patients have atrial fibrillation, number one. Number two, over time, you see reverse remodeling, because you actually do reduce the backward flow, and you reduce the volume ultimately that the right atrium is seeing, because you're actually in a paradoxical way having an initial stretch and then a reverse remodeling. And so, whether you can reverse AF, I'm not sure. These patients have underlying chronic AF in the first place. But when you look at some of the data, and we have to probably see this with MRI and CTs at follow-up, we are seeing both the RV and RA negatively remodeled back to the right direction. So it's an interesting, I mean, we just have to wait for longer term follow-up. But, most of these patients, all of these patients need to be on anticoagulation after having this valve. It's a low flow state. You need a certain amount of back pressure to keep the leaflets mobile. And as you know, you need, certain sort of a V wave of 25 millimeters to be included in the study or the trial, or perhaps even in compassionate use. And so I think this is a space that we need to watch.
10 minutes. Yeah, so that's absolutely understandable. And Katrina, do you have to say anything on this aspect of the long-term effects of this valve on the atrium and the ventricle, and the durability of this valve?
Yes, I mean, I couldn't agree more with what Rishi was saying. I think this was the main concern, of course, in the beginning, or the main concern: what will happen to the atrium if we ventriculize it? First, the first part of it, once we place the valves, of course, we stop the backflow into the cavas. And in order to prevent, because I think this is a major aspect, if you close the tricuspid valve in the tricuspid position, you will see a lot of patients in need of inotropic support, or who will go into cardiogenic shock or heart failure. By using the right atrium as a kind of reservoir, we are able to soften this response and to give the right ventricle and the right atrium time to accommodate. And the loss of weight we are seeing and the improvement in ventricular diameters, I think, reflect the decongestion of the patient. So I think from a logical perspective, we are just giving the heart and the patient the possibility to get rid of the overtop fluid. And in future aspect, it reduces the size. What we have seen from longevity of the leaflets, and as Guillermo Negrelli has mentioned, these leaflets are made of chosen pericardium, especially for that purpose of the low pressure system. So we have seen excellent valve function throughout the also long-term follow-ups, and we have patients now also in the Lithuanian study that have completed their 2-year follow-up. Those patients have been in a very ill patients, very critical patients, and I have to say up to now we do not have any valve deficiencies. But I absolutely agree. We are waiting for bigger numbers from India, from Cleveland, so a lot of patients to see.
Yeah, in fact, we had a concern of this, and I looked into literature, Dr. Kalra, Dr. Puri, and Dr. Hussain, and we found that despite the RA dilating, which again negatively modeled, it did not relate to clinical outcomes. There was no worsening of clinical outcomes at least 2 years, and which we have seen in our cases also, although we don't know what's going to happen long term if the RA keeps dilating. But I think it's more of a vent, you know, it's like a good vent to have rather than.
Thank you. That's because, you know, the first thought which comes to mind is the RA is caught between the devil and the deep sea. So, it's good. Thank you.
Thank you very much.
Effects of the tricuspid regurgitation go away so dramatically, as you also saw in Harish's case, is quite remarkable.
Sir, there is a question on the chat. What happens to the risk of AF?
Any other question from anybody?
What happens to the risk of
so I think
AF?
that we can. Yeah. So as far as the AF is concerned, AF is an independent phenomena, and these patients already have dilated RAs. So we typically don't have to worry about the atrial fibrillation. That has to happen in these. It's inevitable, I must say. So almost 70% of these patients who have been done or who are in studies, they already have AF, and some of them may develop in the due course of time. And since anticoagulation is being given already, it really doesn't matter.
Okay. So there is another question which Dr. Katrina might take up. What is the anticoagulant regimen after device implantation in the short and long period?
Yes, very important question. Because I mean, first of all, from all the patients we have screened and included into the clinical trial, all patients were already on some kind of anticoagulation regimen, either because they were in AFib or they had left-sided valve surgery with a mechanical prosthesis. So that's the first thing. The majority of those patients will be on an anticoagulation regimen. For the clinical trial, we recommended to keep the patient on vitamin K antagonist for 3 months in order to have like the acute phase covered. And then it was left to the physician's distinction whether he would like to change to NORCs or he would like to have the patient staying on vitamin K antagonists. Nevertheless, I want to stress we recommend lifelong anticoagulation because in the venous system, I think it is really crucial and important to prevent thrombus formation.
Totally agreeable. So we must continue anticoagulation to these patients on a long-term basis.
Yes, but as already mentioned, they already are up to now, 100% of the patients we included in the clinical trial were on anticoagulation previously.
So, thank you, Dr. Katrina. There is one more question. What happens to the risk of short PT interval and WPW syndrome?
Okay. Thank you.
So,
if I may answer this question, because I think this is impossible to answer at this point. We have not seen any interference with the His bundle or we have not needed any pacemaker. We had one case where we had to reposition a pacemaker lead, but this had nothing to do with a new appearance of arrhythmia. So I'm not aware of any case where this has been influenced. I think we keep away from the electrophysiologic structures. Until now, there was no need for pacemaker implantation due to exit block or any other interference with the electrophysiology pathways. So I don't think that this will have any interference.
Thank you, Dr. Katrina. Sir, if we could request Dr. Azam, who was, could not speak. Dr. Azam.
Thank you, Ravi. It is a wonderful session. Actually, you know, there is some noise. I am requesting to everyone, please unmute when the speaker is speaking. That will be great to understand our sessions, number one. Number two, there are a lot of questions already discussed, and some question will be more discussed. And one question from Nasser Khan from USA, I think is discussed, that the district valve bicaval valve deployment only depends on the fluoroscopy or any other things. Dr. Katrina can answer.
Yes, of course. Look, for the SVC valve, for the superior vena cava valve, it is completely sufficient to place the valve under fluoroscopy guidance. As I showed, it is helpful to take the CT in order to define landmarks, but the SVC valve is purely under fluoroscopy guidance. You can put, as it was nicely shown in the case, you can put the catheter in the pulmonary artery in order to have kind of a landmark where you want to place the belly of the valve. For the inferior vena cava, it is nice to have a transthoracic echo at the time of deployment. Why do I stress this? Because as Dr. Puri nicely pointed out, we do not need sedation. The patient can be done under local anesthesia, and that means we do not need TEE necessarily. So for the inferior vena cava valve, it is helpful to have a short glimpse with the TTE in order to define how much the struts protrude into the right atrium.
Thank you, Katrina.
I agree with Dr. Katrina regarding this, that you don't need a TE at all.
We should appreciate it. And one more thing I want to know, actually, you know, in subcontinent, in India, Bangladesh, Pakistan, Sri Lanka, much more patients are involved in rheumatic origin. You know, rheumatic fever almost involve more valve, not only mitral valve, aortic valve, and also tricuspid valve. In that particular situation, in severe tricuspid regurgitation with mitral valve, left-sided valve involvement, should it helpful for this outcome?
Dr. Katrina, you are on mute. You need to unmute.
You can unmute yourself.
Yeah, of course. Excuse me. I said I had a little bit of bad connection, but and what we are saying is, I think what we saw also from the data is that if you treat mitral valve, it will of course help the patient if you treat the tricuspid valve either concomitantly. We have had cases.
Dr. Katrina, 1 minute. I'll mute all and you can unmute yourself.
Yeah. So we have done cases where we have treated the mitral valve.
Dr. Abhishek.
Dr. Katrina, you can unmute yourself, please. Sorry about this.
That's fine. What I was saying is that we had cases where we treated the mitral valve first with like mitral clip. Then we were closing the puncture site just to make sure that we have no relevant shunt in the ASD or in the puncture site. And then we were treating the patient with the trick valve. I mean, ideally, I think a two-step approach is better because we're having these patients who are really severely ill. They're severely compromised. And I think it's better to give them the chance, maybe treat the mitral valve first, occlude the septum, follow up on the patient, and then treat the tricuspid valve. I think this is a very good approach. It's very feasible. Even if you treat the tricuspid first for some reason, and then in the later course, you will realize that you need to treat the mitral. As Dr. Puri rightly said, the trick valve will not prevent any future treatment. And I think this is important because we are in the beginning of a long journey. We don't know what is coming up for new treatment possibilities. So you can still go through the IVC valve with any transseptal device and go transseptal, treat the mitral, and then go back without harming the valve.
And actually, we should go for first left heart treatment, then we go for right heart treatment, right? This is the take home back
So.
for the
Yes.
audience, right?
Yeah.
Thank you very much. Now I'm requesting Professor Praveen Chandra as the chairperson make some comments.
Thank you very much.
Good evening, Dr. Praveen. I'm Dr. Puneet Verma this side. If time permits, can I ask a question?
Dr. Puneet, you can ask your question, Dr. Puneet.
Thank you so much. Thank you for introducing this technology. It seems really exciting, no doubt about it. My question to the esteemed faculty is, suppose there is a case where we have to implant this valve in a setting of multiple leads, permanent pacemaker leads coming from into the RA, say a patient on CRT or CRT-D. And how would that impact the placement of the valve in the superior vena cava? Would that really impact, or we are comfortable in this subset of patients as well? Thank you.
Well, if I may say from our experience, this is no problem. I mean, what you will try to do is if you place the superior vena cava valve, you will try to place the pacemaker leads on the inner cavity so not to increase the tension. But from the function, there is no problem because you simply seal it between the vessel wall and the device. So the pacemaker leads will be safely there. And as I said, the only thing that you might want to keep in consideration is if there is already a lot of tension on the leads because they might be old or there might be too many, then it's good to try to shift them to the inner part so that you do not increase the tension by deploying the valve.
And in that sense, it will not cause any paravalvular malfunction or anything, any back leaks or anything. So, since the since the valve and the leads, I mean, there is a space between potential space created. Is that so? Do I understand it right?
Until now, we have not seen any paravalvular leakage due to pacemaker leads. So normally, because of course the flexibility of the device and the flexibility of the venous vessel wall, it will be embedded between the two. Because of this high skirt, you will not have paravalvular leakage because this will prevent it here. So normally it should be done without any problem.
And Dr. Verma, if you saw my case, there was already a lead.
There was a single lead.
Yeah, and the second thing is the belly shape goes like this. So your lead is going to be in the below the belly. So generally, it will never cause a paravalvular.
It will not cause a.
Yeah, it will not cause a paravalvular.
Right. Thank you.
Welcome.
Thank you, Dr. Katrina. I believe this question has been discussed. However, there is a question. Does pre-existing pacemaker lead increase the chances of device migration?
Well, I think this is very much in the sequel of my previous answer. And I mean, of course, if you have a lot of tension on the pacemaker lead, it might prevent the full deployment of the valve. But in normal cases where your pacemaker lead is soft and is not having a lot of tension, it will not cause a problem. I mean, we tend to place the valve a little bit higher in patients with pacemaker leads in order to have enough anchoring in the vena cava superior to avoid migration.
Thank you, Dr. Katrina. So we have answered all the questions that have been put on the chat box. Thank you. And there are no questions.
Hand. Can you ask himself? Dr. Asif Ahmed. Dr. Asif Ahmed. I think he's not in. Okay, Ravi, you can continue.
Yes, thanks, Dr. Azam. If we are done, I would like to hand this over to my colleague who would convey his thanks. Over to Kennedy.
On behalf of Relisys Medical Devices, I take this opportunity to thank all of you, our chairperson, Dr. Praveen Chandra, our moderators, Dr. Ajit, who had to leave all of a sudden, Dr. Sanjeev Patra, Dr. Azam, our speakers and presenters, Dr. Katrina Kis, Dr. Rishi Puri, Dr. Harish Mehta, Mr. Gurima Agreli, and all you delegates and attendees. Thank you very much for being part of this first initiation of Relisys Medical Devices with the TricValve. We will be having the second series of discussions on tricuspid regurgitation on the 13th of March, where we will continue this discussion. And we look forward to seeing you once again. Thank you and good night.
Thank you very much. Best regards from Austria and Europe.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Thank you. Thanks.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.